Hello, everyone. Welcome back. I hope you're all doing super well. Today, we'll be talking about meningitis, encephalitis, and other infections affecting the brain and central nervous system. As the name suggests, it's an infection and inflammation of the meningeal layers. Now, this includes all the three meningeal layers, and that's important to know. So this would be the dura mater, the arachnoid, as well as the pia mater. In terms of where the actual bug is coming from, I think it's good both from a history perspective as well as a treatment perspective, and obviously preventing further occurrences. So you can have direct spread into the meningeal tissue itself, which can be through surgery, particularly neurosurgery, of course, trauma. So have they had any recent head trauma, motor vehicle accidents, and bleeds? So previous bleeds like subdural hematomas, because you have a bunch of blood, as most chronic subdurals present with, you can actually have that harboring a lot of bacteria in it. And it's important to know that as a rule of thumb, the meningeal layers should be sterile. You can also have bugs entering from nearby head and neck structures. So these include the sinuses, the ears, eyes, nasopharynx, and so on. You can also have sepsis in the body from an infection that's from anywhere else. So that could be rhinosepsis, it could be from cellulitis, any source, could be from a pneumonia that has led to a sepsis because of that blood supply can infect the meningeal layers. Of the types of meningitis, you need to know that you either have viral causes, which would be the most common. We have bacterial, fungal and inflammatory, which are relatively rare. The important viruses that cause meningitis include herpes simplex, enterovirus, echovirus. You also have HIV as well as EBV. How does meningitis present? So it presents with the triad of meningism, which is photophobia, headache, and neck stiffness. Now, again, remember that these three symptoms purely mean that this person has irritation of the meningeal layers. Meningism is not exclusively meningitis. You can also have other causes, such as a subarachnoid hemorrhage. What leads us to meningitis over something like a subarachnoid is going to be fever, because subarachnoid should not usually present with a fever. Also, subarachnoids are going to present with a really sudden onset headache. They're going to be really bad versus meningitis that's a bit more gradual onset. You can also have a purpuric rash, quite commonly in children. They may present with a purple or a purpuric rash that's non-blanching, and that is called a meningococcal rash. That indicates that the bug or the likely bug causing the infection is Neisseria meningitidis. And this is a super bad sign because a meningococcal rash indicates meningococcal sepsis, which is really bad and can lead to something called DIC, or diffuse intravascular coagulation, and that's not good. You also need to know what the most common bugs with the different age groups are. Now, I know I talked about viral causes being more common, but bacterial causes are more deadly. And therefore, when it comes to antibiotic therapy, it's really tailored to what bugs are causing the infection. So knowing the most common ones for each age group is relatively important. For neonates, group B strep or GBS is the most common cause of meningitis and most infections. It is a bug that's commonly present in the female reproductive tract and can be transmitted during pregnancy and childbirth, which is why we often screen for GBS with pregnant women at 36 weeks. E. coli, as you can imagine, as the kids are being born, if there's any interaction with fecal matter, this can also lead to E. coli sepsis, and listeria is another big pregnancy-related infection. With kids, the most common cause is Neisseria meningitidis, and with adults, it's strep pneumoniae. The most common cause overall is still strep pneumoniae. For non-vaccinated people, the leading cause or a cause to consider is Haemophilus influenzae. Now, this is perishingly low because we have a vaccine for it, which we give quite extensively. But if the person is anti-vax or doesn't believe in vaccines, then you might have to consider Haemophilus as well. Whereas with viral causes, as I mentioned, enterovirus, echovirus, HSV, varicella, EBV, HIV, all important causes to consider. you often may treat viral causes quite conservatively and consider antiviral therapy if it is debilitating or they have a poor response. So now you know that a patient has come in with symptoms of meningism and a fever, and well, you think to yourself, well, this might be meningitis. What do you do from that point onwards? Do you just start them with antibiotics? No, you want to check a few things before we do that. So what do we look for? First, we want to assess their clinical status. We want to, on history, identify how long this has been going on for, the severity of their symptoms, what the pace or how rapid the onset of their symptoms was, because we know that bacterial meningitis typically has a faster rate of onset compared to viral meningitis. You also want to ask yourself, well, okay, they have an infection. Where did the infection come from? So have they had any recent hospitalizations, any surgeries? Have they had a recent LP? Because if that was contaminated, that can travel all the way up and cause meningitis. Have they been in touch with or recently been in contact with someone who's been sick? IV drug use, a recent viral illness, especially for viral meningitis, and what their vaccination status is, as I mentioned earlier, for Haemophilus influenzae. When it comes to physical examination, there are two things you need to always ask and check for. The first thing is a rash, and this is the first thing you should be looking for when you move to examination. Why? Again, going back to our meningococcal rash, that indicates Neisseria meningitidis sepsis. Not a good sign. And secondly, ask if they've had any change to their vision. Now, this is important because visual changes with meningitis lead us to think, could this person have papilledema, which is swelling of the optic disc, particularly due to raised ICP. Why is raised ICP important? We'll talk about that in a quick second. So going back to your examinations, always start with vital signs, then move on. And for vital signs, hypertension, tachycardia would be a red flag sign. In addition to the rash that I talked about, some meningitis-specific signs and tests that you can do include the Koenig and the Brudzinski sign. So they are both based on the same principle, just two halves of the same coin, two sides of the same coin. So let's start with the Koenig sign. What you do is you have the patient lying supine with the knee slightly flexed, and then you flex the hip further. And the positive sign would be if they have severe pain in the neck or in the lower back. With the Brudzinski sign, you flex their neck, and that triggers pain in their back. And as a reflex, they flex their hip. Now, why does this happen? If you think of the CSF, obviously, which extends from the lateral ventricles to the third to the fourth, all the way down the spinal column, that is also going to be typically inflamed because, as you know, the meningeal layers don't stop at the skull, right? They travel all the way down. And so when you have inflammation and you are flexing someone's hip, you are stretching. You're stretching those meningeal layers, and that's going to cause pain elsewhere. Similarly, if you can imagine the meningeal layers traveling all the way from the lateral ventricles up here, all the way down, if you flex their head, this is going to stretch or pull on those meningeal layers, and they're going to try to lift up their leg to elevate or to reduce that tension on the meningeal layers. And you have a Koenig and then the Brudzinski. So this is Koenig and Brudzinski. I like to think of it, a good way to think of it is Koenig has knee in it, and you're lifting the knee. Hope that helps. In terms of investigations, you can do a BSL quite commonly to check for diabetes control. And also patients with sepsis might have blood sugar abnormalities. In terms of blood, it's really, really important to perform blood cultures. We usually try to take them from two different sites as soon as possible. And you try to take this usually with the LP. And always take blood cultures before you start people on antibiotics. On an FB, we'll be looking for a neutrophilia, typical of a bacterial meningitis, or a lymphocytosis, typical of viral meningitis. A CRP that's elevated is a non-specific indicator of inflammation. We just know that there's inflammation of some sort going on. And it would not be the best indicator if you obviously have other things to corroborate your clinical perspective. In terms of UECs, you want to know baseline levels. You want to know their EGFR because you cannot perform contrast-based imaging on any person with an EGFR less than 30. And they might also have an electrolyte imbalance because of either the sepsis, intravascular coagulation, or they just might have an underlying electrolyte disturbance. In terms of coags, now coags, it's an interesting one because we particularly do them if we suspect meningococcal sepsis, because as I said, one of the complications is disseminated intravascular coagulation, or DIC, and that's going to result, and that is a medical emergency and is going to present with abnormal coag studies. In terms of imaging, we can do a CT brain, and that's important for two reasons. First, obviously, to rule out a subarachnoid hemorrhage, which can also present with meningism. And secondly, to check for increased ICP. Now, why is this important? We want to check for increased ICP for two reasons, and I'll get to those in a second. I know I've said that twice already. And as you know, a lumbar puncture is really important. The reason we check for increased ICP is because when you do a lumbar puncture, you are basically sucking some of the fluid out, right? Now, if you have a lot of pressure in the head, within the skull, and then you have this tiny outlet where fluid can now leave for your lumbar puncture, if that pressure is really, really high, it can push on some of the parenchyma of the brain, which would herniate through the foramen magnum. And then you can have a herniation, and that is going to be not a pretty sight. So you can have a transtentorial herniation, you can have a subfalcine herniation, and all of them are going to be really, really bad because they can cause very quick respiratory depression, coma, and death. So we try to never do a lumbar puncture if we suspect the person has a raised intracranial pressure. So we need to know when not to do it. So as I said, if you have any signs of raised ICP, which could be seen as focal neurology, papilledema, reduced GCS, or if they have concurrent cellulitis. Now, what will a typical LP look like? So normally it should have clear fluid, and it would be clear with viral meningitis as well, because the viral particles are not going to be big enough, versus bacterial meningitis, that's going to be cloudy and purulent. With opening pressure, it just indicates how much CSF there is, and the opening pressure is when you first go in, what is the pressure of the fluid coming out? And that's going to be more raised with bacterial compared to viral meningitis. Lactate, now lactate or lactic acid as a precursor is a chemical that's secreted by all cells undergoing oxidative stress, right? It's a component of anaerobic respiration. And as you can imagine, viruses are not really going to be undergoing much anaerobic respiration. And so they're not going to be producing lactate, versus bacteria, which we know undergo both aerobic and anaerobic respiration. So they would be producing high levels of lactate. With protein, you can have increased protein with both, depending on a few factors. So with bacterial meningitis, quite commonly the dead bacteria can often be picked up as protein. They can also synthesize their own proteins. Similarly, with viral meningitis, with a high enough viral load, you can have viral protein particles being picked up with this. So you can have either a normal or a raised protein. With a cell count and differential, so not only do we look at the number of white blood cells, we also want to look at what the majority of those blood cells are. Are they neutrophils? Are they lymphocytes? So normally the count should be less than 5. With bacterial, we have huge elevations, and that's typically over 1,000. Viral meningitis, it's usually between 10 and 500, not as severe, but you're going to see a lymphocytosis with viral meningitis, while you would see a neutrophilia with a bacterial meningitis. The glucose, which is normally 40 to 75, is going to be decreased in bacterial meningitis. And this is because the bacteria is going to be using up that glucose as a source of energy, while viruses don't necessarily do that. So moving on to now antibiotic therapy. So if this patient was coming to their GP, ideally, we'd like to wait before we can get an LP and some cultures before we give them antibiotics. But if that can't be done, or if we don't have those facilities, we might give something like ceftriaxone or benpen, which can be given both IV or IM, and that's convenient for the GP to give. Always try to get an LP and cultures done, but if you can't get one done, please don't let this delay your treatment. You still want to give them antibiotics as soon as possible. If the pathogen is unknown, so let's say you've just done your LP, you've got your sample, you've sent them off to the lab, you don't want to wait until those samples come back for you to start them on antibiotics. You want to start them on antibiotics right after you've done your LP. So at this point, we don't know what the pathogen is. So in this case, we start them on ceftriaxone, which is the antibiotic, and dexamethasone, which is a steroid. Now, you might be thinking to yourself, well, why are we giving this person a steroid as well? Good question. Especially in children and teenagers, one of the big complications of meningitis are suppurative complications. So with bacterial meningitis, they can often have long-term damage and hearing loss, especially in, as I said, children. Dexamethasone helps prevent that and reduce that by reducing the level of inflammation. Now, the interesting thing about dexamethasone is that studies have found it to be useful only for certain bugs, right? And those bugs include Strep pneumoniae and Haemophilus influenzae. It has not been found to be beneficial for Neisseria meningitidis, which is why if you confirm the bacteria as being Neisseria meningitidis, you continue with the ceftriaxone and you stop the dexamethasone because it's just not effective. It's not a contraindication, but it's just not going to be doing anything. When you go into ETG and when you look at these, this is where it gets a bit confusing. You might be thinking, well, why are we stopping one or continuing the other? It's just that it's not been found to be beneficial. The other thing to mention is when we do an LP and send it off for a culture, we not only get the bug, but also its sensitivity. Now, what does sensitivity mean? Sensitivity just means, is the bug responding well to a particular antibiotic? And usually we test a whole bunch of antibiotics and see which ones work and whether it is resistant to any. Now, if you can see here, I say that if it is susceptible to benpen, de-escalate to benpen. What I mean by this is that Neisseria meningitidis very commonly can be resistant to benpen, right? So therefore, if you can, so although benpen is the best fit for Neisseria, obviously that's not going to be doing anything if it's resistant to it. So we only want to switch them onto benpen if we confirm susceptibility. Going back, you do the LP, start them on ceftriaxone and dexamethasone. Your lumbar puncture comes back, says Neisseria meningitidis. You start them on ceftriaxone and stop the dexa. Once you know that it's susceptible to benpen, you can de-escalate to benpen. Now, let's say the person comes in with a meningococcal rash. Now, because you've attended this lecture, you know that a meningococcal rash or a purpuric non-blanching rash with meningism is likely to indicate Neisseria meningitidis as the cause. Now, technically, we don't know the bug, but we know they have a rash, and we know that this is probably Neisseria. So now, do we give them benpen? Do we give them dexa? Do we give them ceftriaxone? Well, because we suspect Neisseria meningitidis, there's really no point in giving the dexamethasone. Now, do we give ceftriaxone or benpen? Going back to our basic principles, ideally, I would like to give benpen if it is susceptible to it, but I can't confirm susceptibility just yet, which is why I will go with ceftriaxone to begin with. I would get the LP done. Once I have susceptibility, go to benpen. I hope that helps. It's often just mentioned, or you have a bunch of antibiotics given, but you don't really get told why you are giving certain things or making certain switches. So that's why. If you confirm it as strep pneumonia, you can directly go to benpen and continue dexa because dexa has been found to be efficacious. The reason we can go directly to benpen versus waiting for susceptibility is that most strep pneumonia is sensitive to benpen. But this obviously might change with high levels of resistance emerging with most of our antibiotics. If you confirm Haemophilus influenzae, you then, again, give ceftriaxone and continue the dexa. But if you have susceptibility to benpen confirmed, then you would de-escalate to benpen. I hope that helped. These are guidelines that have been changed recently, And these are the most recent up-to-date guidelines. You might be using resources that say otherwise, but please, if you have any doubt, please go to ETG, and that should have the most best and up-to-date information there. A complication I'd like to talk just very briefly about is chronic meningitis, where you have basically a suppurative complication where you don't actually treat the meningitis to a significant enough level, and you end up with meningitis that's chronic. You can also have meningitis, chronic meningitis, with a few other bugs. So the way I like to think about it, bacterial meningitis is short and hard, so it hits you hard, but it's usually relatively acute. You can have some other weird and wonky infections like TB or leptospirosis that can present with chronic meningitis. And because of this low level of chronic inflammation, you can often get adhesions. The inflammation might kind of kink blood vessels, and you may have distorted blood supply causing cortical infarcts. And then you can also go on to develop abscesses. So when we talk about abscesses, a one slide overview is, I think, all you need to know. You want to call us in surgery. So a neurosurge review. Typically, they would like to drain an abscess, biopsy it to check for any tumors, because cancers typically can also present as an abscess, and start them on antibiotics. The antibiotics of choice are going to be ceftriaxone and metronidazole. And lastly, for encephalitis, so encephalitis is inflammation of the brain itself and infection of the brain itself, compared to meningitis, that is just an infection of the meninges. Most cases of encephalitis tend to be viral, although you can have autoimmune encephalitis, although I think that's a bit above your pay grade. Because most cases are going to be viral, our go-to treatment is going to be antiviral therapy, as you got it. And that's usually going to be acyclovir that's given IV. You can also have bacterial encephalitis, that's specifically listeria. That is typical in neonates or not off. You don't have neonates older than 50. Neonates or people older than 50, in which case you would add benzyl penicillin or benpen. I hope that all made sense. That's all we had for meningitis and encephalitis and infections. If you have any questions, feel free to get in touch on my email or through Facebook. I'm more than happy to answer any questions you may have. And as always, please look after yourself and look after your loved ones.